The common variants of ALK gene fusions in lung cancer are most often EML4 ALK. However, there are multiple different variants of EML4 ALK where the ALK portion remains the same and there are different lengths of the EML4 gene that have been identified. We can only pick those up, of course, if we're using testing techniques that include next-generation sequencing methods. If we're using fluorescence in situ hybridization, FISH, or immunohistochemistry, we can't tell what type of EML4 ALK variants they are. There are other variants besides EML4 ALK, so for example, KIF5B ALK. We don't really understand the true significance of these different variants in terms of patient outcomes or differential treatment, although there is some very interesting emerging data that different forms of EML4 ALK may predict different types of drug resistance later on. For example, the two most common variants are called variant 1 and variant 3, and again, those correspond to different lengths of the EML4 gene. And we've seen that there are different resistance patterns. So for example, one gene fusions are much less likely to get G1202R mutations than are variant 3. Whether that impacts progression-free survival on the drugs or whether that impacts overall survival, we don't yet know, but I think it's an interesting area of study and one that can really only be ascertained by doing more modern techniques of testing, including next-generation sequencing. Our patients with ALK-positive non-small cell lung cancer can look like other patients with non-small cell lung cancer. Although typically we think of these patients as being younger and never smokers, that may not necessarily be true. Probably about 35 to 40% of ALK-positive patients are former or current smokers. They are often older as well. Some more recent studies have suggested that the average age of an ALK-positive non-small cell lung cancer patient may be no different than an unselected non-small cell lung cancer patient. And the reason that that's important to keep in mind is that we really don't want to profile our patients and withhold testing based on their characteristics, whether they smoked or not, whether they're young or old, whether they're different ethnic backgrounds, because we know that patients of all types can actually, that their tumors can harbor the ALK gene rearrangement. And so we really should be testing all of our patients for this because there's a reasonable chance that even older patients or patients who are former smokers may harbor this gene, and we want to offer our patients the best therapy.
For those of us who started in the field a while now ago, this has been a fascinating journey with ALK-positive patients. First, the target was identified around 2007, and then crizotinib was approved based on a phase 1 trial with a expansion cohort. Then it was compared to chemotherapy in the second-line setting, then to chemotherapy in the first-line setting, and became a targeted first-line therapy. Those experiences taught us a lot in that, one, if you're going to develop a drug, it's very important to have a target identified and enriched for the patient population most likely to respond. And that with crizotinib, the median progression-free survival was going to be about 10 months. And there were some flaws with crizotinib in that it didn't penetrate the blood-brain barrier very well, and so many patients had either brain metastasis at baseline or developed brain metastasis, and that was a frequent clinical problem and a site of disease progression. Next came the next generation ALK inhibitors, and these were very specifically engineered to be more potent, also have a more narrow spectrum, which reduced the toxicities and penetrate the blood-brain barrier. I think that these have been a tremendous advance in the treatment of ALK-positive patients. We now have several ALK inhibitors available in the first-line setting. Alectinib and ceritinib are approved. We have a phase 3 trial showing the superior of brigatinib to crizotinib, and other ones in development. Alectinib, brigatinib, and ceritinib are also available as second-line therapies as well. And now we have a new agent, lorlatinib, available as well. So there's been a rapid development of many drugs. So I think one of the challenges with identifying patients is the testing methods, and that we continue to struggle with this. Initially, we had the ALK FISH probe, and you had to be positive greater than 15% of patients. There were concerns about the sample quality. This was interpretation of the test was very sort of user-dependent and challenging. Then we developed the ALK IHC test, and that's also FDA approved, which made it a little bit simpler. And more we're moving to next generation sequencing as a method of really testing a broad variety of targets in patients in a single test. And there's sort of two varieties of this. One is the solid tumor next generation sequencing testing, as well as the liquid tumor testing. And I think that this has allowed more patients to be tested, because as a clinician, we just never want to miss a patient who has an ALK rearrangement. The liquid biopsies are right on, I think, revolutionizing the care of patients with non-small cell lung cancer with non-squamous. Historically, we've done tumor biopsies, and then we've done a liquid biopsy if there was insufficient tissue, or if they got an EGFR TKI at the time of disease progression, hoping to identify the T790M in the case of the EGFR. There are more and more studies showing that there's a high concordance between the liquid and the solid tumor biopsy, and the turnaround time is actually shorter with the liquid biopsy, and the panels now get about 70 to 80 genes, which is a broad testing panel, and so I think there's some increased efficiency for this. I think one of the other interesting things are, do you do liquid biopsies, then do the tumor biopsy if the liquid biopsy is negative, because we know there'll be some false negatives, or do you send them both off at the same time, thinking that will be a more comprehensive approach, because we know that also the solid tumor biopsies miss about approximately 10% due to inadequate samples, maybe tumor heterogeneity and other factors.